Hi, everybody. Welcome to week 2 of Rehab 543. My name is Wendy Lokanc-Diluzio, and I'll be facilitating this week's module. This week, we will be talking about using theory and research to understand human sexuality. So, what's ahead? I will begin by briefly discussing what is theory and why theory is important. I'll also discuss the information, motivation, behavioral skills model, as well as the application of the IMB model. I'll discuss the population health promotion model, as well as application of the population health promotion model. The IMB model is a sexual health model, whereas the population health promotion model is a public health model, but it can be applied to sexual health, and it's actually a model I quite frequently use in my practice. Just an aside, the readings touch upon various theories such as evolutionary theory, psychoanalytic theory, learning theories, social exchange theory, feminist theory, queer theory, social cognitive theory, trans-theoretical model, and theory of reasoned action and theory of planned behavior. If you find any of those theories interesting or they apply to your professional or academic work, I'd encourage you to investigate them further. What is a theory? A theory provides us with a conceptual framework for explaining and predicting thoughts, emotions, attitudes, and behaviors. This class is coming from various disciplines which have their own models or theories that they adhere to or subscribe to. I want you to consider how your disciplinary models or theories can be applied to the area of sexual health. Why are theories and models important? A basic understanding of some theories and models can be helpful for us as we look at different topics such as education, health promotion, relationships, sexual behaviors, gender roles, etc. By considering these theoretical approaches, studying human sexuality goes beyond the compilation of random observations. Theory helps us to organize observations into meaningful conceptual frameworks that provide possible explanations for why and how those patterns of sexual behavior occur. It's important to note that no single theory can explain every aspect of something as varied and complex as human sexuality. The next few slides address the information, motivation, behavioral skills model, or the IMB model. And here you can see a depiction of the model. If you're a practical person, you may be viewing this slide with a feeling of dread. You may even be annoyed. Some of you may even be fearful because some of these models are so complex. But again, we want to use models because they help inform our practice by taking ideas that have been evaluated and reviewed and putting them into a logical framework. The IMB model is commonly used to guide the development of sexual health programming. In fact, CCAN used the model throughout the Canadian Guidelines for Sexual Health Education in the newest edition, which was published in 2019. There's evidence that information, motivation, and behavioral skills are linked to performing sexual and reproductive health behaviors. The IMB model proposes that information regarding sexual health, motivation to take action on this information, and behavioral skills for taking action are essential influencers of the initiation and maintenance of healthy behaviors. The IMB model suggests that pertinent, practical, age and developmentally appropriate information that's relevant to the life circumstances of an individual is needed for implementing and maintaining healthy sexual practices. The IMB model affirms that motivation to take action on healthy behaviors rests upon three factors: personal, emotional, and social motivation. The first factor, personal motivation, is the attitudes and beliefs one holds related to healthy behaviors. The second factor, emotional motivation, is the positive and negative emotions related to healthy behaviors. The third factor, social motivation, is the beliefs regarding social norms or social support for healthy behaviors. Although applicable information and motivational aspects are significant components in the adoption of healthy behaviors, possessing appropriate behavior skills is imperative to ensure healthy behaviors actually occur. Behavior skills consist of both objective abilities to induce healthy behaviors, so for example, correct condom use, and the self-efficacy for implementing those behaviors. Let's move on to application of the IMB model. Consider that a low-income 16-year-old sexually active female can lower her risk for STBBIs and pregnancy by using condoms. So what information would be required? Information that is age and developmentally appropriate regarding what a condom is, how to use a condom correctly, and where to access free or low-cost condoms. And the person may also need some basic information regarding anatomy and physiology, STBBIs, and pregnancy. Moving on to motivation. Positive personal motivation for condom use may include that the person believes that the condoms will prevent STBBIs. Negative personal motivation for condom use may include that she believes condoms will take the spontaneity out of intercourse and condoms will detract from sexual pleasure. Additionally, she may secretly want to get pregnant so that she has someone to love and someone who will love her back. Positive emotional motivation for condom use may include feeling good about preventing STBBIs, whereas negative emotional motivation may include feeling embarrassed to access condoms or also being afraid to speak with her partner about using condoms. Positive social motivation may include having a support of peers who use condoms, whereas negative social motivation may include having a partner that doesn't like using them. The last component of the IMB model is behavioral skills. Behavioral skills may include developing the skills through applying the knowledge of where to access the condoms, so actually going to the store and practice buying them. Applying the knowledge of how to use a condom, so for example, practice opening the package and practice using one correctly. Practicing how to broach the topic with her partner, and practicing condom negotiation. So this concludes the discussion about the IMB model. It likely will come up again later in this course and perhaps in other courses in the certificate program. Moving on to the population health promotion model. The overall goal of the population health promotion model, developed by Hamilton and Batty in 1996, is to improve the health of the population through a comprehensive approach. Population health is an approach that addresses the entire range of factors that determine health, and by doing so affects the health of the entire population. Health promotion is commonly defined as a process for enabling people to take control over and improve their health. Population health promotion explains the relationship between population health and health promotion. It shows how a population health approach can be implemented through action on the full range of determinants of health by means of health promotion strategies. Action needs to be taken on the full range of health determinants, which will be discussed in the next several slides. A comprehensive set of action strategies needs to be used to bring about the necessary changes. Action needs to be taken on various levels of society in order for change to be effective and accomplished. And just a couple more notes here. Gender and culture have been added to Hamilton and Batty's version of the population health promotion model, although you cannot see it in the diagram posted. And another thing to take note of is many of these determinants have interaction effects. So for example, education will impact income as well as working conditions. The determinants of health can give us an idea of what makes people healthy. Some of the determinants of health include income and social status, social support networks, education, working conditions, physical environments, biology and genetics, personal health practices and coping skills, healthy child development, health services, sex and gender, and culture. Biology and genetics. Some research indicates that some HPV-related cancers are higher in certain races and ethnicities. In terms of puberty, puberty typically starts between the ages of 8 and 13 for females and 9 and 14 for males. When puberty starts for children, may be genetic. Race can also impact puberty. Some research suggests that on average, people who are Black may start puberty a year earlier than people who are white. And another example of biology and genetics is that risk-taking is also thought to be biological. A teen's brain is wired for risk-taking behaviors, and some people in general tend to be risk-takers. Risk-taking behaviors such as unprotected sex or sex with multiple partners can place a person at risk for STBBIs or unintended pregnancies. Healthy childhood development is another determinant of health. Positive prenatal and early childhood experiences have a huge effect on subsequent health. This is why there's a really large focus on the early years, so children ages 0 to 6 in terms of health promotion. This determinant of health underscores the importance of healthy pregnancies, including the use of folic acid for the prevention of birth defects, the continuity of pre, ante, and postnatal care, vaccinations, which are started in infancy. Teen pregnancy and motherhood has been studied quite extensively in terms of impact on early childhood development. Some research shows that children of teen mothers may be at risk for health problems. One Canadian study of teen pregnancy indicated that teen mothers were more likely to start prenatal care after their first trimester of pregnancy and less likely to take folic acid prior to becoming pregnant or during the first trimester of pregnancy. Now, having said that, it's important to not generalize or make assumptions that every child born to a teen parent will have health problems or be at risk for health problems. Another determinant of health is income and social status. It's not the amount of wealth, but its relative distribution, which is the key factor that determines health status. Likewise, social status affects health by determining the degree of control people have over life circumstances and hence their capacity to take action. So going back to the example of teen pregnancy or teen motherhood, in a Canadian study investigating teen mothers had a greater likelihood of having a lower socioeconomic status compared to their average age counterparts. Teen motherhood was associated with incompletion of high school or post-secondary education. With less education, the teen mother may lack job skills, producing poor economic outcomes. And teen mothers were also at increased risk for single parenthood, at least at the beginning of their child's life, and that also impacted socioeconomic status. Experiencing poor economic conditions puts the teen mother at risk for depression and anxiety as well. Additionally, these economic conditions place the children of these moms at risk for adverse effects on health and wellness. Now, all of that being said, for some teens, becoming a pregnant actually provides great motivation to produce a better life for their children. With strong support from the community and family members, teen mothers can strive and actually be successful at having a life that doesn't lead to poverty. Alberta produces primary health care community profiles for sub-communities within the province of Alberta. And for this slide, I looked at the teen birth rates per 1,000 population for each sub-community within the Calgary zone. I then looked at the percentage of families considered low income in the sub-community and plotted the numbers against each other. As you can see, some of the communities that had the highest teen birth rates also had higher percentages of families considered to be low income. Here is a similar type of graph. For this graph, I looked at the chlamydia rates in each Calgary sub-community and plotted the rates against the percentages of families considered to be low income. In terms of chlamydia rates, those are recorded per 100,000 population. Once again, you can see that the chlamydia rates are highest in the two communities that had the highest percentages of low-income families. I think the community that is the most staggering is the center community, where you can see that the chlamydia rate was 2,590.4 per 100,000 population, and the percentage of families living that are considered to be lower income is around 19%. Another determinant of health is physical environments. Factors such as air and water quality, type of housing, bus routes, and safety of our communities have a major impact on our health. My doctoral studies actually focused around the sexual health of street-involved youth. Street-involved or homeless youth have higher rates of pregnancy compared to mainstream youth. In fact, some research indicates about half of homeless youth have been involved in a pregnancy. Part of my study involved interviewing 8 youth and 6 service providers. Something I learned was many of the youth felt they had access to services and contraception. I also learned that many were not trying to avoid pregnancy. They in fact wanted to get pregnant. For some, getting pregnant meant getting access to services. For others, getting pregnant would help them to turn their lives around. So for example, stop drinking or use drugs. For others, getting pregnant meant having someone that would love them. Another determinant of health is education. Education that is meaningful and relevant equips people with knowledge and skills for daily living, enables them to participate in their community, and increases opportunities for employment. Post-secondary education is very expensive, as you are, I'm sure you can relate. Many people need to work and go to school at the same time. Considering the homeless youth and street-involved youth population, many of those youth end up dropping out of school. This then limits their ability to find work, and it limits them to lower paying work. Furthermore, they may miss out on important life skills, information such as sexuality education. Some interaction or interactive effects with other determinants of health is education relates to income and social status as well as working conditions. Another determinant of health is working conditions or working environments. Meaningful employment, economic stability, and a healthy work environment are all associated with good health. So, for example, here, those working in construction in the 1970s and 80s were exposed to asbestos, not realizing the harms. Now, several years later, they have asbestos-related cancer or asbestosis. Work environments that are flexible and child-friendly positively impact health. Because many people have remote access to work, some employers let employees work from home so that they can take children to and from work. I have to say that I have remote access to work, and it can actually be a double-edged sword because sometimes it causes me to work too many hours, and I'm sure many of you can relate to that as well. Many employers are trying to promote work-life balance, offering on-site exercise facilities and programs, which leads to a positive working environment as well. Once again, considering street-involved or homeless youth, they are at risk for being involved in sex work. In a Canadian study, 5.1% of females and 1.9% of males reported sex work as their main source of income, placing them at risk for STBBIs, pregnancy, physical and sexual assault as well. Another determinant of health is social support networks. Support from families, friends, and communities are all important in helping people deal with difficult situations and maintaining a sense of mastery over their life circumstances. Important to our health is receiving informal support, so that could be from peers or families or communities. Formal support, and that could be from professionals, institutions, or different agencies, as well as societal support, and that might be the attitudes, beliefs, and values that surround us. Social norms or perceived social norms can have an impact on sexual behaviors. Studies show that higher levels of condom social norms and positive attitudes towards safer sex are associated with an increased likelihood of condom use. Health services is another determinant of health. There is a relationship between the availability of preventive and primary care services and improved health. So, for example, baby and immunization clinics, education programs about healthy choices. It's important that health services are accessible, collaborative, or participatory, appropriate, and affordable. It's also important that we meet our clients or our patients where they're at. Harm reduction is a strategy targeted at groups or individuals that endeavors to reduce the harms related to certain behaviors. Examples of harm reduction strategies include offering better access to clean needles or drug equipment via needle exchange programs and safer consumption sites. The harm reduction model acknowledges that abstinence from all drugs may not be realistic for all people, and therefore, although drug use is not condoned, it is seen as essential to implement risk reduction strategies to reduce harmful outcomes related to drug use. Gender and sex are other determinants of health. Gender can be defined as social and cultural expectations of roles and presentation. For most people, their gender matches the sex they were assigned at birth. Others identify as being transgender or gender diverse. Sex can be defined as categories male, female, to which people are typically assigned at birth and may appear on proof of identity documents, unless a person has documentation changed. Gender is an important determinant of health for many reasons. Research demonstrates that people who identify as gender minority have many unmet health needs and have a reduced likelihood of accessing routine, emergency, and preventive healthcare services. This happens when people feel afraid to come to healthcare because of discrimination. Gender is also important because gender inequality leads to health risks for women and girls globally. Sex is an important determinant of health as well. Males and females suffer from different diseases at different ages. Females tend to have higher rates of STBBIs compared to males. And possible reasons for this may be the anatomy of females make them more prone to infections. So, for example, having a shorter urethra, or females typically tend to get tested more often than males. Another determinant of health is culture. Customs and traditions and the beliefs of family and the community will all have an impact on health. The way we parent, including attitudes, beliefs, and values, will also impact health. Research indicates that parent-child communication about sexuality can have a positive influence on the sexual behavior of young people. Unfortunately, parents and their children often have difficulty discussing sexuality with one another. In a Canadian study back in 2005 of mothers and teens, 63% of teens aged 14 to 17 considered parents a source of sexuality information, while 43% felt parents were the most useful, valuable sources of information. That said, 38% had never had conversations about sexuality with their mothers, even though they felt they were important sources of information. When participants were asked what was lacking in their knowledge regarding sexual health, 25% identified how to talk about sexual health issues with parents. In the same study, mothers underestimated their role in their teenagers' sexual health knowledge and behaviors. Immigrant subpopulations may avoid seeking health services. New immigrants are often overwhelmed with adapting to new cultural and healthcare practices. Many come from countries where HIV, hepatitis, and other STBBIs are more prevalent and treatment is inaccessible, and that's why they don't bother seeking healthcare services while they're in Canada. Cultural beliefs may also influence a person's motivation to access health services. Some may try a variety of herbs or culturally accepted medications before seeking medical treatment for STBBIs. Many Canadian provinces lack services and resources that are translated, that are culturally safe and accessible to newcomers, also influencing health. Finally, the last determinant of health is personal health practices and coping skills. Personal health practices are key in preventing diseases and promoting self-care. Just as important are people's ability to cope. Effective coping skills help people to be self-reliant. It helps them to solve problems and make choices that improve their health. Also important in terms of personal health practices and coping skills are having less healthy lifestyles and having the ability to manage stress. Before I move on to the next part of the population health promotion model, I wanted to share this slide. It really speaks nicely to the social determinants of health. So on the left part of the screen, you can see it says the traditional 10 tips for better life. Number 1, don't smoke. If you can, stop. If you can't, cut down. 2, follow a balanced diet with plenty of fruits and vegetables. 3, keep physically active. 4, manage stress. 5, if you drink alcohol, do so in moderation. 6, cover up in the sun and protect yourself from sunburn. 7, practice safer sex. 8, take up cancer screening opportunities. 9, be safe on the roads. And 10, learn first aid ABCs, airway, breathing, circulation. So on the right side of the screen are the social determinants, 10 tips for better health. Number 1, don't be poor. If you can, stop. If you can't, try not to be poor for too long. 2, don't have poor parents. 3, own a car. 4, don't work in stressful, low-paid manual jobs. 5, don't live in damp, low-quality housing. 6, be able to afford to go on a foreign holiday and sunbathe. 7, practice not losing your job and don't become unemployed. 8, take up all the benefits you're entitled to if you're an unemployed, retired, or sick, or disabled. 9, don't live next to a busy major road or near a polluting factory. And 10, learn how to fill in the complex housing benefit asylum application forms before you become homeless and destitute. So there's definitely food for thought. Moving on to the 5 population health promotion strategies. This part of the population health promotion model asks how we can improve health. And the answer is through the health promotion strategies identified in the Ottawa Charter for Health Promotion, all of which will be discussed on the next few slides. The first health promotion strategy identified in the model is building healthy public policy. Public policy should ensure that policy developed by all sectors contributes to health promoting conditions. So, for example, healthier choices of goods and services. Some policies include work safety standards, housing standards, childcare funding, syphilis and HIV testing during pregnancy, and blood screening, as well as other types of policies as well. Currently, the Public Health Agency of Canada recommends screening for HIV, syphilis, chlamydia, gonorrhea, and Hep B at the first prenatal visit, and recommends ongoing evaluation for new STBBIs and consideration for rescreening each trimester to prevent neonatal infection through vertical transmission. So this is important policy throughout Canada. Healthy public policies have also been developed in response to community action. So, for example, the Canadian Red Cross became entrenched in public health scandal when it was discovered that over 1,000 Canadians had become infected with HIV from blood transfusions. Although the medical community was aware of a new bloodborne infection in the late 1970s and early 1980s, strict HIV blood surveillance guidelines were not implemented until 1985. People infected with HIV from blood transfusions launched class actions, and other compensation programs were established. And the risk of HIV transmission via blood transfusion decreased from roughly 1 in 16,000 in 1985 to 1 in 21.4 million in 2015 because of public policies. Another health promotion strategy is creating supportive environments. It's important to create supportive physical, social, economic, cultural, and spiritual environments. A supportive physical environment could be a work environment that has an on-site gym to promote working out during the day. It could also mean having an on-site daycare to promote breastfeeding for those parents who are breastfeeding or chest feeding their children. Thinking about the communities in which we live, a supportive physical environment might mean ample green space for outdoor sports, paths for bike riding, and well-lit roads to enhance safety. A third health promotion strategy is strengthening community action. Strengthening community action is important so that communities have the capacity to set their own priorities and make decisions on issues that affect their health. An example of this is several schools have implemented school health committees that include students, parents, teachers, a principal, and other community members. These committees identify health issues and concerns and then come up with creative ways to address those issues. A fourth health promotion strategy is developing personal skills. We want to develop personal skills to enable people to have the knowledge and skills to meet life's challenges and to contribute to society. So this can be done through health education opportunities. Professional continuing education is another way we can develop personal skills. An example is through the Calgary Zone Sexual and Reproductive Health Education Team offers education programs to different types of community groups. For example, we offer capacity building workshops for teachers related to the topic of sexual health so that they can then effectively teach the sexuality curriculum to their students. We also offer workshops to parents on how to talk to their children about sexual health. And we offer education sessions to youth in schools and in the community. All of these programs aim at the development of personal skills. Finally, reorienting health services is another health promotion strategy. Reorienting health services is done to create systems which focus on the needs of the whole person and invite a true partnership among the providers and users of services. As discussed earlier, harm reduction is one way to reorient health services. Another way is telehealth. Telehealth has become important in terms of health education and prevention of STBBIs, as well as an important way to support those living with HIV or AIDS. Telehealth is the use of information and communication technology to deliver health services, expertise, and information over distance. Telephone, email, and the internet are means of providing telehealth services to those seeking information about STBBIs. And individuals may experience increased comfort using these vehicles as ways of communicating, especially if their questions or concerns are personal or sensitive in nature. The top part of the population health promotion model has the level of action or who we can promote health with. And so the examples provided on the model are individuals, families, communities, sector or system, or society as a whole. The model also demonstrates the need for evidence-based decision-making to underpin the development of population health promotion activities. Evidence-based decisions are required to ensure that policies and programs focus on the right issues, take effective action, and produce sound results. When assembling the evidence required, 3 sources should be considered: research studies that have systematically studied health issues, the underlying factors, the interventions and their impact, both intended and unintended; experiential knowledge that has been gained through practice and synthesized in ways that can guide practice and policy making; and evaluation studies of policies, programs, and projects. These sources provide evidence-based on examination of past activities. In addition, trends can be analyzed to identify emerging issues, and visioning can be done to create preferred scenarios for the future. Evidence-based decision-making is thus an art and a science where collective wisdom and vision, along with empirically derived knowledge, play worthwhile roles. So the conclusion of this presentation relates to the application of the population health promotion model. So an example is a principal called My Program and said that sexual health was an issue at a particular high school and wanted my program to come in and fix the problem. The first thing my team did was gather more information to ensure the school community indeed thought there were issues to address, and it wasn't just the principal that thought there were issues. We ended up conducting 6 focus groups. We conducted 98 student surveys, 8 parent surveys, and reviewed literature on teen sexual health. Some of the issues identified through the focus group surveys and literature review were consequences of sexual activity. The students talked about concerns related to STBBIs as well as unintended pregnancy. They talked about issues related to their relationships. Adolescents stated that they were embarrassed or afraid to speak to their partners about sexual matters, and they don't always discuss sex because they're fearful of losing their partners. They also talked about unplanned intercourse. Sometimes they said sexual intercourse just happened and therefore they did not plan ahead and use contraception or condoms. The social environment. Many students said that sex was a norm in their school community, and many students stated that although everyone talks as though everyone is doing it, in actuality not everybody is, and that there was sometimes pressure from outside of the relationship, so for example media and peers, to have intercourse. They talked about contraception. Condom utilization was affected by cost, embarrassment, or the belief that condoms take away pleasure from having intercourse. Knowledge was identified as an issue. Generally, there was a lack of knowledge. Some participants felt teens were knowledgeable about sexuality but chose not to act on that knowledge. And some of the people in the focus group said it's more complicated than just knowing the information. You actually have to have the ability to act on that information. Cognitive egocentrism also came out in the focus groups, as well as looking at the literature, that students stated that sometimes they made unsafe decisions because they did not think that something bad could happen to them. They thought that they were invincible, and again, unplanned or unintentional pregnancy wouldn't happen to them, or they would not get an STBBI. It would happen to someone else. And finally, alcohol use and sexual decision-making was identified in the focus groups, the surveys, as well as the literature, that it was an issue because youth felt that alcohol was used almost as liquid courage to become sexually active. So many people actually used it as an excuse. They said, I didn't know what I was doing, I was drunk. Participants stated that they are less likely to use protection when they're drunk, putting them at risk for an unplanned pregnancy or an STBBI. After we collected the information discussed in the previous slide, we formed a committee, and that committee consisted of students, teacher, nurse, principal, to decide what topic we actually wanted to address. And so this would be the health promotion strategy of strengthening community action, so working together as a community to solve the problems or address the problems. We then decided on the level of action, and that level of action was students and parents. So the who is the level of action, and that was the school community. And then we decided on the determinant of health to address, or the what, and that was personal health practices and coping skills. The health committee decided to focus the topic or their efforts on the topic of alcohol and sexual decision making. Over the course of 2 to 3 years, we developed, implemented, and evaluated several interventions related to raising awareness about the relationship between alcohol use and sexual decision-making. Many of those interventions were then offered to other high schools within the Calgary zone. We created lessons on substance use and sexual decision-making. Sexual health educators then went into several comm classes to teach those lessons. We delivered parent education sessions. We wrote a proposal and received funding to develop a professional looking pamphlet and poster. And we wrote a proposal and received funding to develop a Smart Grad resource kit, which targeted grade 12 students about to graduate. Thank you for listening to this presentation. Please take some time to reflect. What was the most important concept you learned from this presentation? So what? This was important because, and now what? Two things I want to explore further are